Okay, you can start now. Swapnil, you can start now.
Yes, sir. Yes. Professor Parul Institute of Nursing, Parul University. In the webinar series of Parul Institute of Nursing, today we are going to talk on the assessment of Pritila Gandrani ma'am. Vice Principal come Professor Principal and Professor and Apollo College of Nursing, Chennai, India. Ma'am has completed her PhD Nursing from the INC India in 2019. Ma'am has completed MSc in Nursing from Omail Archi College of Nursing, which is affiliated with Tamil Nadu, Dr. MGR Medical University, Chennai. And ma'am's specialty as well as area of interest is medical surgical nursing as well as critical care nursing. Ma'am has completed BSc Nursing from Christian Medical College and Hospital, CMC Vellore, Chennai. Ma'am also affiliated at the Tamil Nadu University and Dr. MGR Medical University, Chennai, India. Ma'am have total 26 years of experience in the clinical as well as teaching in nursing field. If we talk about the professional achievement as well as certification of ma'am has completed adult advanced life support course in 2012 from Apollo Hospital, Chennai. Ma'am has completed certificate course in palliative care in 2008 from Indian Association of Palliative Care. Lean Six Sigma Green Belt score ma'am has completed in 2011 from Robert Apollo Mission 2012 and Six Sigma 50, 500 and 5000. Ma'am has also completed critical care provider certification in 2013 from the Society of Critical Care Medicine. In the educational qualification, ma'am also completed the Master in Business Administration in 2021 from Anna University, and ma'am also have Master in Psychology degree, which is completed in 2001 from University of Madras. In the lifetime membership, ma'am is a member of the Trained Association of India, Nursing League of the Christian Medical Association of India, Alumni Association of College of Nursing, Christian Medical College and Hospital, CMC Vellore, Indian Association of the Palliative Care, Pediatric India, as well as the Society of Pediatric PhD Nurses of India. Members of Accreditation Committee, ma'am is currently working as a Tamil Nadu Nurses and the Midwifery Council, Chennai, Indian Nursing Council, New India, Tamil Nadu, and Tamil Nadu Dr. MGR University, Chennai. Ma'am is registered PhD guide and advisory committee members under Tamil Nadu Dr. MGR Medical University since April 2021 to till date. Ma'am is also working as advisory committee member of Rajiv Gandhi University of Health Sciences, Bangalore since April 2021 to 21. Ma'am has guided more than 30 PG as well as 50 UG research projects as well as students in nursing field. More than 20 research articles in 20 peer-reviewed journal, master trainer for simulation also. She has been research speaker, presenter of scientific as well as the concept paper more than 60. She is working as the editor of Tamil Nadu Nurses as well as the Midwifery Council Medical Surgical Nursing also. I would like to hand over the session to ma'am. Ma'am, over to you. Once again, welcome to the platform Parul University.
Thank you all very much. Greetings to you from Apollo College of Nursing, Chennai. I'm very happy to present this session on the assessment of critically ill patients. I thank the organizers and my good friend and colleague of mine, Mr. Swapnil. I thank him for the opportunity and the organizers for allowing me to present. I thank each and everyone from the Parul University for this opportunity to present on critical care nursing. So today's topic will be the assessment and clinical examination of critically ill patients. I'm very happy to share this presentation among nurses. To be a nurse is a special privilege to do what nobody else will do, a way that nobody else can do, in spite of all we go through. That is to be a nurse. This is the institution where I'm working, Apollo College of Nursing. So about 25 years since this institution started, and we have programs from starting from BSc Nursing up to PhD Nursing in our College of Nursing. Now let me go on to the topic, the assessment of critically ill patients. So we'll focus the topic with these learning objectives: to define critical illness, to enumerate the principles of the management of critically ill patients, and to learn to be thorough with ABCD approach of assessment of critically ill patients, to describe about A to Z assessment of critically ill patients, to enumerate the different severity of illness scoring systems that are in use today in the critical care units. Now let me begin the session. Who are critically ill? Critical illness is any disease process involving any system which can cause physiological instability leading to disability or death within minutes or hours. Mainly, there is a physiological instability which can quickly go to a disability or death within a matter of minutes or hours. A critically ill patient is one at imminent risk of death, and the severity of illness must be recognized early, and nurses need to take appropriate measures to assess, diagnose, and manage these patients, to recognize that the patient is critically ill, and to do immediate management. That is most important. Now let us just look at the 7 C's or core values of critical care unit care. We are team players, so communication plays an important role. Compassion for the patients and their families, empathetic, having consideration of the ethical legal rights of the patients, being careful or meticulous in what we do, looking at the comfort of the patient. Though the patient is surrounded by so many invasive lines or gadgets, equipment, etc., the comfort of the patient, and consistency in the care that we give, being systematic when we do a monitoring or surveillance or reporting, being consistent in our care and achieving closure for effective completion of care till the patient gets improvement or deterioration. Now let us look at the principles of management of critically ill patients. So you cannot do everything. Assign responsibility to the correct person, delegate that work. Initial assessment and resuscitation is priority for the person. Resuscitation and saving the life of the person. Then you look at focus history, perform focused physical examination, then perform basic investigations as required, recognize the patients who are at risk, especially the elderly, the immunocompromised patients, polytrauma, comorbidity. More than 1 or 2 vital systems are involved. Then assess the response to initial resuscitation. Assess the intensity of support. What support are required? Monitoring systems or inotropic support. So look at the intensity of support. Seek help for specific problems that may require expertise. Make a working diagnosis and plan so that you can carry on your work. Have a working diagnosis to do. Don't forget your relatives. Do the briefing of your relatives. Counsel the relatives. Remember, time is tissue. We are working at saving the life of the person. So the vital organs like cardio, respiratory, renal, these parameters are very, very important. So your timely intervention can save the life as well as the tissue of the person and prevent the permanent damage. And remember, there is no separate time for assessment or management. Both go hand in hand. Are my slides moving? Shall we continue? Are my slides moving? Who needs ICU admission? Sureka? Can you follow on Facebook page? So who needs ICU admission? The priority for ICU patients are patients who will be requiring life support for organ failure. Particularly, we are worried at the organ failure of the heart, lung, or kidneys. Intensive monitoring and therapies that can be only provided in the ICU environment. So invasive ventilation, like endotracheal tube to mechanical ventilation, patients on continuous renal replacement therapy, or invasive hemodynamic monitoring. So these are the patients who will be in the ICU as priority 1. These patients may also require the use of ECMO therapy, extracorporeal membrane oxygenation therapy, to improve their circulation perfusion, and intra-aortic balloon pump to support the heart in supplying the blood to all the important organs and tissues. So that is the priority 1 patients. ICU priority 2 patients are patients who will require intensive care therapies, but who will not opt for a CPR in case of cardiac arrest. And ICU priority 3 are patients with organ dysfunction who will require intensive monitoring and who are in the they are on the verge of getting triaged elsewhere. These post-operative patients also will fall on ICU priority 3. ICU priority 4 are patients with low probability of recovery or survival, who will not, they are DNI, do not want to be intubated, or DNR, do not resuscitate patients. So when there is a limitation, always there is a limitation in our resources. So patients are allotted to the ICU as per their priority. And who doesn't need ICU care? So patients with palliative care needs, patients who are terminally ill or moribund patients with no possibility of recovery. Such patients fall in the palliative care priority 5. Examples of such patients are patients with metastatic cancers for whom the additional chemotherapy or radiation therapy may not be a suitable option, who will opt for comfort care. So ICU patients, these are the patients who will be in our ICUs. So you can see the priority 1 patients who will require ICU care will be critical patients who are unstable, who will need minute-to-minute monitoring, and who will require invasive mechanical ventilation support, and also continuous extra-renal replacement therapy, etc. Some of the admission criteria for depending on the particular organ failure. So these are the things that we consider while patient is admitted to the hospital. So whether the patient, what is the age of the person, what is the severity of illness? There are different scoring systems for severity of illness. The age of the person, the functional status of the person, and coexisting diseases or comorbidities. What is the physiological reserve? How much of physiological reserve, respiratory function can be managed by him? What is the prognosis of his condition? Availability of suitable treatment options in the particular center. Response of the patient to the treatment that is given so far, or the patient is not responding, or refractoriness of the condition. Recent cardiopulmonary arrest, or 1 or 2 arrests the patient already had and has been resuscitated, and now there is another arrest. Anticipated quality of life out of the event. So all these things are taken into consideration while we admit the patient to the ICU. We follow the classical medical model. We go in this sequence. We take a quick history. We do the physical examination. We assist for all the investigations, come to the correct diagnosis, treatment option we plan. And then as the treatment is done, we see the response of the patient to the treatment. And then we address the concern, what is causing the problem. We need to focus on that and correct it. So this is a medical model that we follow in our ICU. Okay, now let us look at the 7 C's of CCU. Are you with me? I hope you will remember these core values in your critical care unit. Communication is the key. Communication, we work as a team, we communicate. Okay, we get the patient consent, we collaborate with the team, we work with the team, we look at the compassionate care for the person, consideration of the rights, etc. So these are the 7 C's of the CCU care. Now let us come to the assessment part of it. So we follow the ABCD approach that we will be discussing. Preparation of patient. Even before the patient is received into our unit, we make preparation in the ICU. ICUs are well prepared. even when there is no patient at all. ICUs are well prepared as a unit. Then on the patient, we perform the primary survey, which is nothing but ABCDE approach. And then we do the secondary survey. Once the patient is stabilized, we do the review of the systems, the secondary survey we do. And then a definitive care intervention is planned for the patient, and we go by the treatment plan. We carry out the interventions as part of the treatment plan. So let us look at the preparation. What preparation is needed in the ICU? So we have all the emergency equipment, which may be high-tech gadgets. We may have different monitors. We may have different infusion pumps, syringe pumps, nitrous oxide therapies we may have. We may have the ventilators. So all these emergency equipment are to be in good working condition. They should have the standard operating procedures, and we should be familiar with it. And simplest thing of all, it should be kept under charging. Many of the times, practically what we see is it may not be charged and not up to use, and then you need to borrow or you have to arrange for the equipment. The drugs and supplies in the ICUs, as per protocol, we have the drugs that are needed in the emergency crash cart, and also non-drugs or other supplies like disposable items that are in use for the patient. So that needs to be kept in ready for the patient's condition. And then meticulously checking them at every shift. Checklists need to be prepared, and we have to check that these drugs are in preparation. If we are not prepared for the battle, then we cannot fight the battle effectively. You need to keep prepared all these things in readiness before you receive the patient and start with your assessment. Now, who are the history? Let's look at the history of the patient. So when we look at the history, we have the key informant. It may not be the patient. It may be the patient's relative or a bystander or a close friend or family. So what are the chief complaints of the patient? Look at them in chronological order. Before 2 days, for example, I had started with 2 days, I was feeling extremely weak. For last 6 hours, I'm having chest pain. Then before 1 hour, I vomited. Then the patient was collapsed before 10 minutes and brought to the hospital. So the complaints can be brought in important things in chronological order. Then history of the present illness. Pertaining to the present problem, history of the present illness, when it actually started. Any surgical procedures. Review of the body systems. What are the important systems? Is there anything abnormal? How is the functioning of the cardiac, respiratory, renal, or the liver, etc. And history of allergies. Allergies to medication, allergies to food. And what is the medication that the patient is getting? The important medication that we will be concerned will be medications like beta blockers or seizure drugs, or they were on digitalis or steroids. So some of these medications what the patient was taking should be known to the nurse. So we follow for information gathering a format we call it by an acronym SAMPLE. S-A-M-P-L-E. Sample. The sample is symptoms, objective and subjective symptoms of the patient, which brought the patient to the hospital. The allergies. A stands for allergies. Allergies to food or medications. Then medication. What medications patient has been taking for last 2 weeks or so. Past medical history. P stands for past medical history. L stands for the last meal. Last meal is significant because we need to know, can we intubate the patient, or the patient can be shifted for surgery, or is there any effect of the last meal on the present condition? And then what are the E stands for the events. Events are precipitating factors which led to the presentation of this condition. And another E again, environment. So this is sample. S-A-M-P-L-E. Hope you will remember them. Then previous primary care or hospital records are also source of information. Then talking to the relatives pertaining to the patient. Quick history from the relatives. So these are the relatives can give additional information. So we may not know the other habits of the patient. So abuse. All that can be, we can come to know through the talking to the relatives. So managing the resources, gather the information, and then identification of the needed help. Arrange for staff, triaging staff, resuscitation, to do the IV cannulation, for drawing the blood, for sending for sampling or calling referrals, consultations to identify the people and designate the roles and responsibilities. Please follow the SBAR format while talking to our relatives, to our colleagues. We follow the SBAR format. SBAR stands for, S stands for situation, B stands for the background factors, A stands for the assessment findings of the patient, R stands for what are the reporting and recording, what interventions you have done, what more can be done. So reporting or turning over the patient. So SBAR framework we follow while handing over to our colleagues. Now, after doing the initial history taking, we follow this primary assessment. There is always this ABCDE sequence that we need to follow. This is the life-saving measure. This is the way we give priority to the patient care. A stands for airway, B stands for breathing, C stands for circulation, D for disability, and E stands for exposure or environment. So these are the ABCD assessment that we need to start right away. So when we look at the patient, A, airway, is the airway clear? Does the patient need airway support? Is a patient needing intubation? No, airway is not patent. Patient cannot maintain as airway. Then prepare for inserting an oropharyngeal airway or nasopharyngeal airway. Then preparing the patient for intubation, endotracheal intubation with our medical team. Med team. Then breathing, assess the patient's distress, rate, simplest thing, chest movement, bilateral air entry equal or not. Does the patient need oxygen? CPAP. Does the patient need CPAP support? CPAP support can be given in a non-invasive manner, continuous positive airway pressure support through a tight-fitting mask. We can improve the oxygenation of the patient. If the patient needs invasive mechanical ventilation, intubated and ventilated. Circulation is established by starting the venous access. So venous access, putting the patient mainly on a large bore needle, 18 gauge, green color IV cannula, yes. So and then starting on the IV fluids. Most safest one will be to give normal saline for patients for whom we don't know whether they are diabetic or how far is their blood sugar. Then supported vasoactive drugs, inotropic supports are given as necessary. So A and B we manage, then we take care of the assessment of the circulation part. So circulation, we are checking the pulse rate, rhythm, volume. So check the peripheral pulses. If not, don't waste your time. Check the carotid pulses. Remember, don't palpate the carotid pulse bilaterally on both the sides at the time. So one side you check for the carotid pulse. Don't spend more than 10 to 15 seconds palpating for them. Okay. So pulse is present. Then you note the quality of the pulse, the rhythm and the volume. So if you have access to BP monitoring, non-invasive BP cuff, or if the patient is an arterial BP line, well and good, you have it on the monitor, arterial BP. Check the simplest thing, capillary refill, less than 2 seconds. So check the color of your nail bed, press it for a second, then you release it. How much time it takes for the blood flow to color to return. So we always look at all the hemodynamic parameters, as well as we look at the urine output of the person. A person's urine output can be a very important thing to know about their perfusion, blood flow in general to the entire body, and renal perfusion. Are they going into circulatory shock, etc. can be found out by knowing the urine output. So expected urine output is 0.5 ml per kg per hour, which works out for a 60 kg person. Yes, it will be less. It should be up to 30 ml, at least 30 ml. So less than 30 ml, that indicates poor renal perfusion. Then look at the disability of the patient. We have certain scales for assessing their disability, like the AVPU scale. I'll come to it little later. We'll discuss. Then Glasgow-Coma scale. Then check the pupillary response, bilateral pupillary responses. Then you can look at the plantar reflexes, localizing. Patient is moving all 4 limbs, all that you can check for disability. So we go by this order in primary assessment, A, B, C, D. And initial investigations may be called for a complete blood count, urea and creatinine, glucose, ABG. ABG, we determine their PaCO2, PaO2 levels, pH of the blood, lactate levels, and coagulation, bleeding time, clotting time, And we look at the, if needed, they go for a chest X-ray, of course, and then urine or sputum and blood culture and ECG. So this is the initial assessment that is done using ABCD approach. So we have certain adjuncts to the primary survey. We can have the cardiac monitor to check their ECG, and we have their vital signs. We can check their vital signs by connecting to the monitor. We can check the vital signs, pulse, respiration, blood pressure, and also ABG. If not, ABG is not available, even a venous blood glucose will be, venous blood gases also you can check initially till you get a ABG. Handy, we have gadgets, pulse oximeter for knowing the saturation of the patient. The patient can be, you can pass a urinary catheter to know the urine output, and we can measure the renal perfusion, gastric catheters to know about the patient's gastric function, and we can aspirate and we can decongest the stomach. So these are the things that are done as part of the primary survey. So we go by this order. You check the heart rate. If pulse rate is not obtained, you check the heart rate. The apical pulse is enough. At the right side, you can check. And then the respiratory rate. Then go for the systolic blood pressure. Blood pressure is recordable. At least systolic BP may be recordable. Temperature of the patient, oxygen saturation. Look at the ask questions. Know about the level of consciousness of the patient. Hourly urine output. Assess for biochemical analysis, and don't forget the pain assessment. So this will serve, these parameters will serve as a baseline for us in critical care unit while you're doing the assessment of patients. So when you check the airway, so how do you ask the patient? So you look at the patient, approach to the patient, speak slowly, calm manner. And if the patient talks normally, then the airway is clear and there is perfusion to the brain. So immediately the patient is talking, so airway is intact. So you can support it by giving oxygen. So we give oxygen through a face mask. So preferably we start with a non-rebreather mask, and then we go on for the other rebreather mask according to the ABG values of PaCO2 levels. If no response to speech, then you do the look, listen, and feel. So what do we do? Look, listen, and feel. We look at the airway. Observe for signs of airway obstruction, whether there are any secretions, blood, vomiters, or foreign body, or sometimes the tongue even can fall back and obstruct the airway. So sweep the tongue, gently suction under direct vision you can do and clear the airway. And if the airway is clear, you can turn the patient to recovery position. If there is airway obstruction, and if the patient is using accessory muscles of breathing, central cyanosis, all this you look at the airway. Signs of airway obstruction, you can see patient is using all the accessory muscles of breathing. The nasal flaring is seen. Nasal flaring. And patient is using the accessory muscles of breathing. Like sternal retraction is there, intercostal retraction, pulling in is there. They are using the sternocleidomastoid muscles. So these accessory muscles they may be using. And then next is listen. So you can listen very well at the airway noises. So look at the gurgling noises. This is indicating secretions or food which is aspirated, snoring sounds, grunting. In short breaths, the patient may be grunting, unable to take a good breath. Hoarseness or changes in the voice quality. Wheeze, a high-pitched musical sound, or stridor, upper airway obstruction can produce a harsh sound, shrill sound. And then there may be a silent airway with no air movement whatsoever. So that's an emergency. So you look at these respiratory parameters, then you follow the look, listen, and feel. So you feel for the movement of air. So these are the things we do in look, listen, and feel of the airway. Now next, after the A, we go for breathing. So always E as nurses, we can do it. Okay, we can see the expansion, rise and fall of the chest, whether it is effortless or the patient is having increased work of breathing. If the respiratory rate is within 12 to 20, it is normal. So less than 8 or more than 30, that should be alarming for you. Noise free. Okay, there is no, if the normal breathing should be noise free, effortless. If there is wheezing, stridor, or a rattling sound under the mucus sound, then there is a abnormality. There can be quickly, the airway can get obstructed, breathing will require support. And watch for the position of the trachea. You can keep your hand in the midline, and you can palpate for the position of the trachea, whether there is a shift of the trachea from the midline. So if there is a collapse of the lung on one side due to pneumothorax, automatically the trachea may be pulled to the unaffected side. So please remember that position of trachea, movement of trachea will occur to the unaffected side. That means one side of the lung has collapsed completely. There's complete collapse of the lung, like tension, pneumothorax. So look for the airway and the breathing. Some of the clinical features that the patient is having inadequate oxygenation. Patient is restless, delirious. Okay, they are making sounds, they are talking irrelevantly. Patient is feeling drowsy. Patient has got cool extremities, cool and clammy extremities, cyanosed appearance, or the heart rate is increased. Patient is having some arrhythmia and low blood pressure. So these are the signs of inadequate oxygenation. And then what are the signs that patient has got some respiratory distress? Patient is unable to speak in full sentences, breathless, tachypnea, unable to complete full sentence. Just one or two words they may answer to you when you ask them. They may be keeping their mouth open mouth. They may keep and they may breathe, and they may have air hunger, flaring of the alar nasi. And then they may have paradoxical breathing. So paradoxical breathing is nothing but the opposite direction of movement of the lungs compared to normal breathing. So as you breathe in, you inhale air inside, then your diaphragm gets pushed down, okay? Then your lungs get inflated with the air. And then when you breathe out, the same thing, diaphragm moves up, the lung moves inward, and the air is coming out. So the opposite of which occurs in paradoxical breathing, that is a sign of rib fracture or a flail chest. So these are the sign abnormal breathing that you need to observe. So you look at the airway, then you look at the breathing. You will be worried if you see the following signs. So respiratory rate is more than 30 or it is less than 8. Unable to speak half a sentence without pausing to catch the breath. Patient is agitated, confused, or comatose. And the patient is cyanosed. You can see the central cyanosis where the lips and tongue is blue. And then saturation is less than 90%. So less than 92 itself is a warning sign that saturation is dropping. And this is a worrying sign for you. Now coming to the C, circulation, we look at the peripheral and central pulses. So we don't wait to catch the radial pulse or the femoral pulse. Immediately we shift and check the carotid pulse, the rate, rhythm, volume, and symmetry. The skin temperature is a good indication of circulation. If the patient is warm, then circulation is good. Cold and clammy, circulation is poor. Heart rate you can check at the apical pulse. Check the blood pressure. Particularly, you will need to calculate the mean arterial pressure from the blood pressure reading. Systolic BP should be at least 90. Capillary refill, jugular venous pressure. Look at the condition of the central veins, jugular veins. So up to 30 degrees, you raise the head end of the bed. Look whether the veins are distended or they are flat, neck veins. So both are alarming. So urine output is an important indicator, very dependable, reliable indicator of renal perfusion and circulatory status of the person. And we have advanced monitoring devices. So bedside echoes can be performed. A central line can be cannulated and CVP we can measure. We can do an arterial BP line, invasive blood pressure monitoring we can do. So hypotension is a late feature of shock. Initially, the patient may have increased heart rate. So increased heart rate will be a warning sign for us even before the patient goes into a shock. So rapid thready pulse is an indication that patient's BP is falling. So there are some conditions which lead to the circulatory problems. You will be alert to these conditions when the circulation is affected, like acute coronary syndrome and MI, ST elevation or non-ST elevation, MI. Then there are arrhythmias, hypertensive heart diseases, valvular conditions. Hereditary cardiac diseases can result in such complications. Certain drugs can affect. And then electrolytes, deranged electrolyte values. These are the primary causes when circulation gets affected. And then secondary causes when there is poor circulation are asphyxia. Asphyxia can be occurring due to strangulation or drowning when the airway is getting obstructed. Or hypoxemia can lead to poor blood pressure. When the blood level, oxygen levels are low, then the BP may not be maintained. So perfusion to all the tissues in the body cannot be maintained. Or there could be a blood loss due to trauma or even internal bleeding or rupture of an aneurysm, or internal bleeding can lead to it, or the perforated ulcer. So this could be the secondary causes where there's an internal bleeding leading to poor circulation. Septic shock is an important cause which leads to low blood pressure. Please be alert when blood pressure is low. This may indicate a septic shock. There may be some port of entry of these organisms. It may be a urinary tract infection, or it may be a skin infection, a cellulitis may be there, or it may be any infection in the body can lead to a septic shock. And then hypothermia. So hypothermia can affect the circulation. So we look at the primary survey A, B, C. So what are the warning signs? So you will be alarmed if the BP, systolic BP is less than 90 mm of Hg, because we look at something called as MAP. I'm sure you have learned how to calculate the MAP. MAP appears on the monitor itself, but you can also calculate the MAP. So MAP is calculated by using this formula. It's systolic blood pressure plus 2 into diastolic blood pressure, the whole thing divided by 3. Systolic blood pressure plus 2 into diastolic blood pressure divided by 3. So if you arrive at a mean arterial pressure MAP reading 70 to 110, it is acceptable. We aim at keeping the MAP more than 70 to ensure cerebral tissue perfusion. So when you think of reducing the BP to control aneurysm bleeding or hemorrhages, please ensure that patient's mean arterial pressure is at least 60 mm of Hg. And the other warning signs are GCS, Glasgow-Coma score of less than 12, and a pulse rate more than 150, or a pulse rate less than 50. Both are warning signs. And respiratory rate more than 30 or less than 8. And a urine output of 0.5 ml per kg per hour. So these are the warning signs of severe illness. So please remember, even without any extensive devices, with these parameters, you are able to identify and save the person by doing a timely intervention. Now we have in the hospitals, some of the hospitals you might have come across is EPOC. EPOC is nothing but electronic point of care diagnostics. So a simple few drops of blood in the emergency or in the critical care unit can tell immediately the pH, the ABG value or a VBG, maybe the blood may be venous blood also. So from that we can know the pH, PaCO2, PaO2, sodium, potassium, chloride. We can know the ionized calcium, glucose, lactate, creatinine, blood urea nitrogen, and then we can know the hematocrit. So these are the parameters we can obtain. Within 5 to 10 minutes, you can estimate them, and you can zero in on what is the system which is mainly deranged, which system is actually under problem. So quickly, instead of waiting for extensive tests and working under the risk of suspicion, etc., this will quickly tell you what are the deranged parameters, and we can do a life-saving intervention to stabilize the person. Coming to the D, A, B, C we covered. Coming to disability. So disability is measured using the AVPU, the simplest one, or the Glasgow-Coma scale, and then the pupillary examination, and then plantar response. So this is knowing about the neurological status of the person. So you all will remember this AVPU, I think. So A stands for you mark it when the patient is awake. B is when the patient is not alert, but when he is responding to your verbal stimulation. P is when the patient responds to painful stimulation only, not to your words. But if you give a painful stimulation, like a peripheral or a central painful stimuli, you can give to patients a fingertip, nail bed, or you can apply a central pain stimulus you can give by applying a glabellar pressure or a sternal pressure, and patient is responding to that, he is moving. Then when the patient is completely unresponsive, then you mark it as U. This is quickly we can do the neurological assessment. In the CCUs, we follow a flow chart, and we check the neurological status and maintain it by using a GCS check. So all of you may be familiar with this GCS. G for eye opening, verbal response, and motor response. What is the response of the patient to your words? How is he talking? How is he using inappropriate words? And what is a motor response? When you ask the patient to lift the arms above the shoulder or put out his tongue, is he obeying the command? Is he moving? He's withdrawing to pain, or he's decorticating, abnormal flexion or decerebrating he is doing. So this is the GCS score. You know the maximum score is 15 and the minimum score is 2T. So GCS, we make an assessment to know about the disability of the person. Pupillary response and plantar reflexes also are helpful. Now coming to the E of the person. So in assessment, you can't afford to miss out the skin rash, wounds, pressure injury, any bruises. So you need to remove the clothes of the patient, protecting the modesty of the person, check completely. For a patient at risk of spinal injury, log roll the patient. And C for spinal injury, we check the rectal examination, assessment of the anal tone, perineal sensation, and temperature. Then after checking thoroughly, protect the patient from excessive heat loss and maintain the temperature of the patient according to his body temperature. He may need either a warmer if he's feeling hypothermic, or if he's hypothermic, we need to cool the person. So this is about the E, A, B, C, D, E. So that brings to the end of A, B, C, D, E. Now let us go ahead with some of the other assessment that we do in the ICU, A to Z. So A, B, C, D, E, we are already finished. Now coming to the F. F is the fluids. What type of fluids the patient requires? Does the patient have a line? Is the line patent? Is it functioning? Is the fluids received by the patient? How much more fluids the patient is required? The hydration status of the person. And then GI condition. So GI gastric functioning. Okay, how is there a paralytic ileus, or the patient is having a poor bowel motility? Is there risk of aspiration from the retained stomach contents? Is there any GI bleed? So all these are the things which will be done in G. In H, we do for the hematology. Mainly we look at the complete blood count. Is there any need for blood replacement? The bleeding and the clotting time of the person is very, very important. And then the lab values, that we take the blood and send for biochemical lab values. I for infection, is there a risk of infection? Okay, does the patient show signs of any infection? Then J, jugular vein pressure. Jugular vein pressure distension is an indicator of CVP. Central venous pressure is estimated through jugular vein pressure. You need only 2 scales or rulers to measure the JVP. Even if the patient is not having a central line, you can measure the JVP of the person. Fluid overload or flat veins, fluid overload or a cardiac failure may have a jugular vein distension. Then the temperature of the person. Is the patient hypothermia? Septic shock sometimes manifests as hypothermia. So Kelvin, we denote temperature by the unit K, Kelvin. So K. L, remember the invasive lines. The invasive lines the patient in the ICU will be having. Mainly it may be the airways, it may be the lines like IV line and NG, or a Foley's catheter, it may be, or the intra-arterial line, it may be. So central venous pressure monitoring. So Transcan's catheter. So what lines the patient is having, and care pertaining to these lines to prevent infection. So these invasive lines always place the patient at risk of bloodstream infections. Remember that, and the care. M stands for the medication that needs to be administered. Medication to control the arrhythmia, medication to maintain the blood pressure of the person. So these medications need to be administered in a timely manner. And then EN stands for nutrition. Of course, in the CCU, until the patient is stable and the bowel movement is there, we don't start on the nutrition, oral nutrition. But the patient should be started on nutrition early. It's a stress ulcer prophylaxis and improves the recovery of the person. So adequate protein intake may improve or recovery or speeden up the recovery of the person. Then O stands for nothing but old notes or old medical records which are relevant to the present condition. Pain score. So we may do a pain score for patient who is not able to indicate numerical rating scale or visual analog scale. FACES scale may be used for pain assessment. Queries. We need to have certain questions to guide our treatment. And then R, relatives. relatives need our full debriefing and comfort. Okay, and then what is happening to the patient should be updated to our relatives. And S stands for sedation and skin care. So sedation and patient's pain management is to be in a balance, so that patient does not become sedation, and there should be a vacation for our sedation also, that we have scales like RASS, Richmond, agitation, sedation score. So to know about the patient sedation status. And skin care is also important to prevent the risk of getting any infections or pressure sores. Patients are extremely vulnerable patients who are very thin, or they may be obese, or their skin may be exposed to incontinence. So these are the risks. So skin care is important. Then T, trauma. So look for signs of trauma, known or unknown, hidden trauma, all these things, please look. And U stands for ultrasound. The ultrasound that is done for a patient in critical care unit may be a screening ultrasound for the abdomen, or maybe an echo. And then V stands for venous stasis. Look at the peripheral edemas, venous stasis, any dilation, superficial dilatation of the veins. Watchfulness, that should be our word. So patients, however experienced we are, still we need to be watchful. Every patient, every minute counts for the patient. Every derangement of parameters, we need to be watchful. And then X-ray may be ordered to confirm any problems with related to the lines, to confirm the placement of the lines, and for chest X-ray, for pneumonia. So X-ray may be done in a routine basis, even every day it may be done. And why is the patient in the ICU should be a query in our mind. Does the patient need ICU care, or he can be shifted to a step down or to a room setup? So depending on the patient's requirement. So why is the patient in ICU? So what other systems are not addressed? What problems have led the patient to the ICU? So that needs to be focused. The primary consultant and referrals need to be made. And Z, don't forget the importance of sleep. Sleep and wakefulness to be maintained in the correct circadian rhythm, daytime wakefulness, nighttime sleepiness. Otherwise, the patient will go into conditions like ICU psychosis. So please remember the A to Z assessment that we follow for critical care unit patient, or even in other settings it may be used. So in the ICU, what are the items that we usually do? We have a CCU flow chart which captures the vital signs. You need to check the vitals, and you need to see the monitors and to maintain them, the trends. Intake, output. So careful recording of intake output is done for every 8 hours, and also at the end of the day it is total. So outputs, intakes, all the IV fluid dilutions, NG tube feedings are counted, oral feedings, everything is counted. And outputs, urine output, stool, watery stools may be there, chest tube drainage. So see the drains, wound drainages, and then NG, aspirations to dependent drainage. So check the outputs and monitor the output, and have to see that there is a positive balance of the intake and output. Then antibiotic duration is also monitored by the nurse. So we mark it in red color, the day of duration. So there may be different people keeping giving antibiotics, different consultant. So the nurse keeps a tab on them, the day and dose of the antibiotic. And there is no need for unnecessary continuing of antibiotics. So you have to alert, and you have to stop the antibiotic continuation of antibiotic unnecessarily. For mechanically ventilated patients, we have certain parameters. So we record the date of intubating the patient, the size of the ET tube, the lip line of the patient, if the patient is on mechanical ventilation, what type of setting the patient is on, either on a IMV or the patient is on a SIMV mode or a CMV mode with pressure support or volume support. How much pressure support is how much PEEP we are keeping. Also, we need to keep a tab on peak and plateau pressures and compliance. So what is a peak plateau? Pressure need to be recorded. The patient's respiratory rate, minute ventilation, all this need to be recorded. So updated ICU checklist we need to develop, and we need to do it instead of patient seems normal, same status quo. Instead of that, we should be meticulous in our ICU recording, identifying any derangement and reporting. And you can use this word ICU checklist, fast HUGS bid. So this should be assessed daily once on each patient. So in ICU care, this is one important thing that we follow. Fast Hugs BID. FASTHUGS BID. F stands for feeding. So feeding is the practice now, is the recommendation is to start enteral feeding early. Start enteral feeding early. Analgesia versus sedation. A is analgesia management to control the pain and for promoting the patient's cooperation with procedures, sedation if they are restless, and then maintaining the record of sedation vacation as appropriate. Thromboprophylaxis is very, very important. So the patient may be placed on sequential compression devices or TEG stockings. So, and the patient may be put on certain low molecular weight heparin. So thromboprophylaxis is very important, and early ambulation as advocated. Then the head of the bed should be elevated up to 45 degrees. This reduces the aspiration risk. So that's about FAST. And now we move on to HUG. HUG is H for head of the bed elevated up to 45 degrees. Ulcer prophylaxis. So stress ulcer prophylaxis. The patient may be put on pantoprazole or sucralfate. So if the patient is nil by mouth, this needs to be taken very seriously. Then the patient should be, we should ensure that the feeding tube is in the right position, and then feed continuous feeding without overloading the patient may be given. Instead of giving intermittent bolus feeding, now we follow continuous drip feeding we follow. And then that also is under a control of the infusion, feeding pumps. Then glucose control, the optimum glucose level will be 85 to 180. We observe that sometimes even patients who are non-diabetic also, when they are faced in such a stressful situation like critical care, when they are there, when they are having a lot of cortisol and other effects, their glucose may shoot up. And that may impair their recovery. So please remember the optimum glucose control, HUG. Continuing, BIDS. So BIDS is bowel. BIDS, bowel. Bowel, what is the condition of the bowel functioning? Then indwelling lines and catheters. So femoral lines are not preferred nowadays. So even if the patient is on even central line placement, usually internal jugular vein or subclavian veins are preferred. Femoral veins are at risk of contamination, should not be left more than 3 days. Internal jugular vein or subclavian veins for only up to 7 days. And if the patient is on a PICC, it has to be removed 14 days. And this is very important to date the line, date of starting the line. And we keep a tab on that, we monitor that, and we ensure that the tubes are unnecessarily not there on the patient. So because they can lead to bloodstream infection. And Foley's catheter can lead to COTI or catheter associated urinary tract infection. So as long as their purpose is served only, they have to be in place. And D stands for de-escalation of antibiotics. Antibiotics need to be, once the cell culture and sensitivity reports have come, there should be, the antibiotics need to be de-escalated. Only what is necessary for the person needs to be given. So I hope you remember these past BID for CCU assessment of the patient. This will be beyond my scope of my topic, but you all will be remembering the types of care bundles that we follow in the ICUs. Like we have, if it's a surgical patient, WHO surgery safety checklist, you can have urinary catheter care bundle, Clostridium difficile care bundle, because patient is on multiple antibiotic at times, that's a risk for Clostridium difficile, ventilator assisted pneumonias, VAP bundle, palliative or comfort care bundle, pressure area care bundle, sepsis care bundle, and venous central vein catheters bundle. So these bundles are evidence-based interventions that we need to follow. This ensures that we will not miss them. We will ensure the care is done as per guideline. So these bundles, we need to check whether this care has been done, and that we do the, we just keep a assessment of that, whether the bundle care has been performed by us or not. So coming to the secondary survey, so after primary survey is completed, we can go ahead with the systematic detailed examination. So the patient has no need for resuscitation. Patient has become stable, and now we see the evaluation of the patient to the treatment. We keep a quick reassessment we do, and then we do the secondary survey. typically in our ICUs, we follow certain tools for decision making. Now, there are certain algorithms for helping us to know the prognosis of the patient. This is the severity of the patient's condition. Will the patient come out of the ICU? Will he come out of this mortality? What will be the mortality and morbidity of similar type of population? So that is what the scorings are used. The common one that we see is Apache 2. This Apache 2 is nothing but acute physiology and chronic health evaluation. To Apache 2 stands for the severity of disease classification system. So this has been used in adult patients. So this Apache 2 scoring, it uses these physiological variables: rectal temperature, MAP, heart rate, respiratory rate, oxygenation of the patient, arterial pH of the person, bicarb, potassium, sodium, creatinine, hematocrit, and the total leukocyte count and GCS of the person. So they are plotting these parameters and above normal or below normal. It can be high abnormal or it can be falling within the low abnormal range. So the score which is less, around 0 or 1, the patient will have a lesser Apache score, means that patient has got better chance of survival. The more high abnormal, a very low abnormal, extremes of scores, that indicates higher Apache score indicates that patient will have a poor recovery period. So you can see the hospital mortality rates based on the Apache scores. Now there is Apache 3 also. So this Apache 3 score makes use, it's an addition to Apache 2. Apache 2 mainly you saw all these parameters, blood hemodynamic parameters. Apache 3 is related to neurological parameters. So here again, if the patient is oriented, alert, the score is less. If the patient is decerebrating or decorticating and he's not able to find out the pain, not localizing the pain, then the score is higher. So Apache is 3 score. And now we have the modified early warning scores. Many of the hospitals have implemented in the critical care unit and even in the wards also, this mu scoring. Mu scoring is based on parameters like respiratory rate, their pulse rate, their systolic blood pressure, temperature, and the CNS or neurological status. So this is very, very important. So this even before the patient goes for a cardiac arrest. Many of the incidents can be prevented if the nurses take regular rounds and they check these parameters. So a score of per normal parameters will give a score of 0. If there are deranged parameters, either respiratory rate is too high or it's too low, then it may go to extremes. So these parameters are regularly maintained and the Muse warning score alerts the need for any intervention. You can ask for a reference. You can call the MET team. If the score is 2 or 3, then 3 needs immediate intervention. 2, they need to come and see. So it's no call is wasted. Nobody will say, why did you call me unnecessarily? Because our goal, all our health team members' goal is to save the life of the person. So before the person develops any cardiac arrest, we can see for any reversible events and we can stop it by doing these Muse. Then there is an important parameter that is PaO2 divided by FiO2 called as the PF ratio. PF ratio is we obtain their ABG value PaO2, for example 97 mm of H, and then their FiO2 value. So if they are on a ventilation of 50% or 40% oxygen FiO2, that will be 40. If the patient is on room air, then it is 21% FiO2, 0.21. So PF ratio is calculated. So PF ratio normally it should be more than 400. P by F ratio should be more than 400. You can see hypoxemia less than 400. And a value less than 200 indicates the patient has got a critical respiratory failure. So this PF score is important while you calculate the SOFA score. So SOFA score is currently used related to sepsis. So this is an assessment tool, sequential sepsis related organ failure assessment score. So this also makes use of the similar parameters: respiratory status, PF ratio, coagulation, the platelet count, and liver, the total bilirubin value, cardiovascular, the mean arterial pressure calculation, CNS, the Glasgow-Coma scoring out of 15, renal, the blood urea nitrogen, the creatinine value and the urine output. So you can see if it is within normal parameters, the score will be close to 0 or 1. And as it becomes deranged, the score can increase. So SOFA score is another significant scoring system, particularly used for sepsis patients coming with infection who can go for septic shock. This is early detection and prevention of complication. So a mortality rate of 90% or more can occur if the SOFA score is 15 to 24. So this is like a baseline, and then you do every 8 hourly, you may do it depending on the patient's condition. You may score it more frequently, and this helps us to decide on the intervention that needs to be done, aggressive intervention that need to be started. We can alert the team for aggressive intervention. And the MODS has been there for a long time. So MODS also similar parameters like our SOFA score, similar to SOFA. It is also capturing the PF value, creatinine, bilirubin, and the cardiovascular status of the person, the platelet, and the neurological status of the person. So this is about the MODS scale. So now the patient has been done a primary, we got a quick history, we do the primary assessment, we did the secondary assessment. Then if the patient is stable, or if the patient can move to a step-down ICU, he can be weaned off the ventilator. Then he may be shifted to a step-down ICU or a ward, and then or semi-ICU. If the patient's, unfortunately, if the patient's physiological status is deteriorated or irreversible, and there is not much of outcome that's going to be, then the patient may be shifted to a room side with comfort care as the criteria. So this is the discharge criteria for the patients. So critical illness is any disease process which can cause physiological instability leading to disability or death. So severity of the illness must be recognized as early as possible. As early as possible, you do it and initiate some intervention, then we can save the life of the people whom we are caring for. So that brings me to the end of the presentation. And I have few questions. I just want to have 1 more minute. Remember, I want you all to get motivated. You are not just a nurse. Sometimes we think why our students sometimes tell us, why did I choose nursing? You are not just a nurse. Take pride in what you do. You are saving lives. You are an important person in the health team. Make a difference in someone's life. Your knowledge, your competence can save many people's lives. And activity, can you recall what is sample in history taking? SAMPLE. Can you take a minute for recalling what does sample stand for? There's no live audience, I think, Swapnil. But let me tell the answer. Please check whether you got it right. S stands for symptom. A stands for allergies. M stands for medical history. P stands for the precipitating factor, last meal consumed, and E stands for the event or exposure. So S stands for the symptom, A stands for allergy, M stands for medication, P, the precipitating factor, last meal, and E stands for the event or exposure to the environment. 2 E's. This is one of the disability assessment tool. There's a hint which is given. This is a disability assessment tool. This is useful for neurological assessment of patients. Day to day, we are using it in our CCU flowchart. Glasgow Coma Scale. I hope many of you would have got it right. And next, coming to the one of the hemodynamic monitoring that we do in the ICU. It's present in our CCU master chart. Central venous pressure. Central venous pressure monitoring. Very important. Central venous pressure monitoring, or indirectly the JVP Very, very important to know about the right atrial condition, to know about the fluid overload or heart failure, or patient needs more fluid correction, there's bleeding, circulatory failure. So if there is a flat vein. So CVP assessment is important in the CCU. Apache. Apache, what is the expansion for Apache? Acute physiology and chronic health condition. So that is Apache. We have Apache 1, Apache 2, and Apache 3 to know about the severity of illness score. Now coming to the components assessed in SOFA score. This is the last question. Can you recall what are the components that are assessed in a SOFA score? The condition and the parameter. There are 5 important systems and parameters pertaining to that particular system. Starting with the respiratory rate, the pulse rate, the mean arterial pressure, the platelet count, the urinary output, total bilirubin. So these are the components assessed in a SOFA score.
Yeah.
I've come to the end of the presentation.
Hello. Okay, thank you so much, ma'am, for this interactive session. Really, our students as well as faculty members also appreciating to you your knowledgeable session, and I hope it will be useful for us, our BSc as well as the master students in future. Ma'am, so many students are requesting, they want content of this session. If possible, can you please share it?
Yes, we can do that. No issues. I can share it.
Yes. Okay.
I can share it over to you. I can share it to Mr. Swapnil sir from Parul University, so students can get it from sir. Thank you very much for the opportunity. All the best to all the nursing fraternity members. All the best in your careers. You can make a difference. Have a nice day. Shall we end the session? Or will there be any more inputs from others?
Hello.
Thank you.
Yes, ma'am. Thank you so much, ma'am.
Thank you so much. Thank you so much for the opportunity. I learned myself a lot, reviewed my knowledge, and it was good. Thank you so much. Now I'll end the meeting, and now I'll leave the meeting.
Thank you so much.
Thank you. Bye. Bye. See you.
Yes. Bye. Have a nice day.
Thank you.